Good afternoon. Hello, welcome to the Sarcoma Foundation of America's panel discussion, Sarcoma and Coronavirus, What Now? My name is Lori Hoffman, and I'm Director of Advocate Engagement and Public Policy at SFA. And we are really glad that you have joined us for this follow-up to our earlier coronavirus session that we held in April. But before we begin, we do have some housekeeping to go over, and I'm going to go over the format and some logistical details of the webinar. We today have 4 panelists and a moderator. Today's session will begin with the panelists sharing some comments on the impact of COVID-19 on sarcoma patients. After, the moderator will ask the panelists questions that were submitted prior to today's discussion. If time permits, the moderator will also include additional questions submitted through the question component of the webinar. The information contained in this session is intended to be for educational and informational purposes only. It is not a substitute for medical advice from your physician about your specific situation. Today's discussion is being recorded, and the discussion will be archived, and a link will be posted to the SFA website. All participants are muted, and any questions or comments can be submitted through the webinar's question portal. And now I'd like to introduce today's panelists. Dr. David Kirsch is the Barbara Levine University Professor at Duke in the Departments of Radiation Oncology, Pharmacology, and Cancer Biology. After graduating from Duke with a BS in Biology, he completed the MD PhD program at Johns Hopkins School of Medicine. After an internship in internal medicine, Dr. Kirsch trained in radiation oncology at Massachusetts General Hospital. In 2007, Dr. Kirsch moved to Duke, where he uses radiation therapy to care for patients with sarcomas at the Duke Cancer Center. Dr. Kirsch is the leader of the Radiation Oncology and Imaging Program in the Duke Cancer Institute and serves as Vice Chair for Basic and Translational Research in the Department of Radiation Oncology. Dr. Kirsch's laboratory utilizes sophisticated genetically engineered mouse models to study mechanisms of tumor response to radiation and immunotherapy. Next, we have with us Dr. Brian Van Tine. He is Associate Professor of Medicine in the Department of Medicine at Washington University in St. Louis, Missouri, where he is the Sarcoma Program Director at the Alvin J. Siteman Cancer Center. He pursued his postdoctoral fellowship studying mouse genetics and genomics and tumor xenografting while clinically specializing in the treatment of sarcoma. His laboratory is dedicated to understanding the metabolism of sarcoma. Also with us today is Dr. Kurt Weiss, Associate Professor in the University of Pittsburgh Department of Orthopedic Surgery, Division of Musculoskeletal Oncology. He is the Vice Chair for Translational Research and Director of the Musculoskeletal Oncology Laboratory. He established and developed a translational sarcoma research program at the University of Pittsburgh that continues to grow and thrive. His research focus is understanding osteosarcoma metastatic potential and developing novel therapeutics to disrupt the metastatic process. He is also interested in the metastatic programs of other sarcomas and sarcoma-associated cachexia. We also have today with us Dr. Breland Wilkie, an Associate Professor in Medical Oncology at the University of Colorado School of Medicine. She is involved in patient care, clinical trials, and laboratory research, particularly focused on immune therapies for sarcomas. Again, thank you to all of our panelists for joining us today. And now I'd like to introduce SFA's Executive Director, Brandy Felser, who will moderate the discussion this afternoon. Brandy?
Thank you, Lori. Thank you, everyone, for joining us today for part 2 of our webinar series. Our first webinar was about a little over a month ago, but it seems like such a long time with so many things continuing to change. We once again had many people register for the program today, and we received many questions. But please remember that if you submitted a question, and you may not hear your particular question, but our goal has been to group submitted questions into themes. If you have questions to submit through the question portal during the discussion, please be sure to make them specific to sarcoma and COVID-19. The panelists are unable to answer questions about your specific treatment. Since this is part 2, we changed the format slightly and have asked our panelists to kick off the discussion with some comments about the impact of COVID-19 on sarcoma patients, and then we will move into the question portion of the program. So Dr. Van Tine, will you start us off and maybe give us your comments and thoughts about the impact you've seen on sarcoma patients?
No, I would like to begin by thanking the SFA for once again hosting a good panel of friends. these are, the people around me are colleagues I've worked with for, at least a decade, and people I think very highly of. And, coming together, we've all had various different impacts because we're in various different parts of the country. Being in the central Midwest where I am, it's been a very interesting impact. I think first, we've had a lot of adjustments to how we're doing clinical trials. The good news is where I am, we didn't shut many of them down, but we did alter how they were being run. And what happened from a patient perspective is, well, some of the research around the drugs they were getting was shut down. They weren't prevented from getting access to the drugs that may be changing their therapies. We were still doing T-cell infusions. We were still giving a lot of novel new drugs. I've actually accrued a trial that the SFA has actually helped support in the middle of all this. And so we've been working really hard. I think the thing that most has directly impacted patients is, the ones I admit for ifosfamide are no longer allowed to have visitors. And so, we've been social distancing our hospital so that there are no visitors right now. And so when people get admitted for, these long chemotherapy infusions, they're now alone. And I think this has been a big adjustment. And, it's not fair, but it is one of the biggest impacts I've seen, both emotionally and from an isolation standpoint. It's been a hard transition for needed therapies, especially curative therapies.
Great. Dr. Wise, you want to share your comments?
Hey, everybody. Happy Memorial Day weekend from Pittsburgh. I echo a lot of what Brian said. I think very highly of everybody on this call. And we're all at Sarcoma Centers of Excellence. So it's really nice to hear how other people are dealing with these problems and these issues. From the surgical standpoint, we're starting to gradually dial in things that maybe weren't super emergent, but probably shouldn't wait around. Now, sarcoma surgery really doesn't fall under that. If you needed a sarcoma surgery a month ago or a couple of weeks ago, you got it. And that will continue to be the case. We will continue to look after those serious issues. But I'm talking more about sort of benign aggressive conditions like desmoid tumor or giant cell tumor of bone, things that aren't necessarily life or limb threatening, but are not something that you can just ignore with impunity. So those sorts of things are starting to come back online, if you will, and we're starting to do a little bit more of those things. While I feel like we've done a good job of looking after the sarcoma patients and what they need when they need it.
Right. Dr. Wilkie?
Hi, good afternoon. And again, I just want to echo everyone else and just thank you for the invitation to be back with you. So, I can't believe it's been a couple months since all of this happened when we shut down. And, on one hand, I think what we've seen, at least in Denver and in many places across the country, is that the shutdowns and the social distancing, they actually worked because most places, the numbers of COVID cases are either coming down dramatically or, in the case of our institution, we didn't have to call in all of our reserves. We were able to avoid that peak. Thank God most of our cancer patients have been, remarkably healthy and my patients have been able to avoid these infections. And so as, moving into this new era right now, I think we're kind of entering a new normal to some degree. And I think that's even harder too, because initially everybody was sort of in shock and panic and, it's okay, you can make these really extreme adjustments for the short term, but now the questions that are coming are, well, what happens next? Like, okay, we're opening back up again. You're telling me I can come back to clinic and have scans done or procedures, and what changed exactly? And how do we know this isn't going to flare up and we're going to be right back where we started? So I think on one hand, we feel like we've made it through, hopefully, the worst of the worst to begin with, but I think there's still a tremendous amount of anxiety, and it's not just our patients, but I think all of us wondering how things are going to move forward.
Yeah, that's very true. Our newest member to the panel, Dr. Kirsch.
Hi, thanks so much for including me this time around. I'm a radiation oncologist at Duke University in Durham, North Carolina. And we've made some significant changes to the way we've been taking care of our sarcoma patients. Some of the care has been the same, But when possible, we've been adding more telehealth or telemedicine. So we've been communicating with patients either by phone or sometimes with televideo visits as well. Of course, we can't do all of our care that way, but that's been a big change for us, that we've been integrating that into our algorithms. New patients, of course, need to be seen in person. And when patients come for radiation therapy, they're coming daily, Monday through Friday, to get their radiation treatments. But for certain visits, we've been able to do their health care over the phone when possible. I think that's been our biggest change so far. Fortunately, we've also had kind of a moderate pace of COVID infections in our area. It hasn't been as overwhelming as in some of the bigger cities around the country. And I think probably a general theme for today's discussion is that kind of the response or the answers to the questions that we'll get are going to depend on how prevalent the COVID infections are in each community. And that's really going to affect kind of what the risk is for each individual patient, and also how your healthcare team can take care of you best.
Yeah. Dr. Kirsch, I have a follow-up question to that. It's one of the questions that we received in advance. And as you mentioned, telehealth, telemedicine has taken on a much bigger role throughout the past few months during the quarantine period. Do you foresee that telehealth visits will continue to be a more preferred way to visit with the doctors, or at least continue to be an option? How do you think that will play into moving forward?
Yeah, I think that's a great question. I think one of the outcomes of COVID-19 is going to be that for some medical problems, they can be handled well by visits over the phone or through a televideo visit. I think that to take care of sarcoma patients, we do need CT scans or MRI images or other kinds of special tests. And so I think that a patient can't stay in their house and get the same kind of care as they can if they come to the hospital or the clinic, at least to get the imaging studies. And depending on where the tumor is located, sometimes a physical exam can really complement the history that you can get through a telehealth visit. But having said that, there could be scenarios where if in your community COVID-19 infection rate's very high, that the risks of going in to visit the doctor may outweigh the benefits of seeing them face to face. And so I think that certainly for the time being, I think you need to talk to your own healthcare team, your own sarcoma team, and talk to them about the risks and benefits of coming in for a face-to-face visit versus a visit that's done through telehealth. And they'll give you the best advice for you for your situation. But in the future, I do think it's going to be an option going forward for many patients.
Okay. All right. Great. Dr. Weiss, I have a follow-on question from the first chat that we had, and it is about restrictions and surgeries. And now that you had mentioned, surgeries are continuing, but are there any updates for patients? And if a patient is about to have a surgery, should they be tested for COVID-19 prior to surgery?
Okay. That's actually a really good and really important question. So I'm glad that it was asked again. So first of all, are we doing more elective operations at the University of Pittsburgh? The answer is yes. So I have a lot of partners that do, for example, hip and knee replacements. And we talked about last time that hip arthritis and knee arthritis can be pretty miserable, but they are not life-threatening issues. So now those operations are starting to happen a little bit more often at our center. And the second question, which is very important, is should that patient be tested? And I think the answer is absolutely yes. I think you definitely need to be tested for a couple of reasons. First of all, if you test positive and you're not feeling terrible, well, you can certainly put off that operation for a couple of weeks if it's an elective thing. If it's not an elective thing, well, then we know that you're a patient that might struggle a little bit down the road. So we can be prepared to look after you a little bit more aggressively should you require that. There's some data out of Asia suggesting that if you are COVID positive and subsequently undergo surgery, that act of intubation, of putting a breathing tube in you, that can really sort of poke the bear, and that can make you get a little bit sicker than ordinarily you wouldn't have been. So if you are going to have a procedure or a surgery, I think that you absolutely $1,000,000% should be tested. It gives us a lot of important information on how to look after you down the road. Is that pretty much the consensus at other places?
Yeah, I can say at Duke, all patients going to the operating room are getting a COVID test prior to surgery date.
And I would agree that we're doing the exact same thing here, but I think there's another level to this. I mean, if you think about it, there are only so many sarcoma surgeons in the country. And if they end up getting infected by a patient, they're not going to be able to help anyone else. And so this is, a protection on both sides, because that surgeon may be asymptomatic and then go on and spread it even more. And so, this is part of that social distancing and a part of our risk assessment so that we don't actually cause fires in hospitals.
Yeah. And Dr. Kirsch, is there a question that came in actually through our question portal, but is there any, does any patient would need to get tested for COVID maybe before they're starting radiation treatment or chemotherapy or anything like that?
Yep, that's a great question. Initially when the pandemic started, our testing capacity was severely limited. And now just over the past few weeks, our capacity's increased enough that all of our patients now that are going to get chemotherapy and radiation therapy, they're getting tested before initiating treatment. Patients that are getting radiation therapy alone at our center are not yet getting tested, but I'm hoping that as the testing capacity increases even further, that maybe one day we'll be able to test all patients. I know from colleagues that are in areas of the country that have much higher prevalence of COVID-19, like in New York City, some of their cancer centers are testing every patient before starting radiation therapy. And so I think it's something that, as Dr. Van Tine was just mentioning, part of the reason to get tested is because we don't want to put patients at risk. We want to let them recover from COVID-19 before suppressing their immune system with chemoradiotherapy. But also we want to try to limit the risk that they could bring COVID-19 into the cancer center and potentially infect other patients or staff.
Yeah. Dr. Wilkie, if a sarcoma patient tests positive for COVID-19, will there be any impact on their treatment after recovering from the virus, or is there anything patients should expect to be different? Do we know that?
Yeah, that's a great question, and I think one that's really, at the forefront of everyone's mind. I mean, like I was saying, we have limited experience with our patients getting this virus, and maybe if you polled all of the sarcoma docs across the country, talking with people in New York, we might be able to learn more. But in general, there are some patients that will go through COVID infection and have no symptoms, so they may not even know they had it. And so patients like that, right, we wouldn't expect there to be long-term issues with their ability to receive treatment. There are some data out of centers that, after a nasty COVID infection, there can be permanent lung scarring or injury. And, that's something where, yes, that could potentially be a major issue, particularly for somebody who needs radiation therapy, I would think, or, some of our chemotherapies like gemcitabine that can have lung toxicity. So I think the short answer is, we're just so early on that we don't really know. But I think it all depends on the individual patient, and I think that's why it's so important that we get to the point where we can test people so that we can plan accordingly. And again, it all goes into that risk benefit ratio. Is chemotherapy more important and more critical to save your life than the risks of potentially having a COVID infection?
Yeah, Dr. Van Tine, another question came in through the portal that kind of relates to this, and this again may be something we don't know yet, but do we know if sarcoma or chemo patients or radiation can develop antibodies? Is there any effect of chemo on the body's ability to develop antibodies if they were indeed infected with COVID-19?
I think that's a good question. I think the data that we would use to look at that would probably be the data for flu. And so you can, the flu vaccine works in cancer patients getting chemo. It doesn't work as well if you're not, then when you look at somebody who isn't getting chemo, but they still work. So I would expect when we're looking at antibody tests, you will get enough of an immune response at those tests when we start doing blood tests later to figure out who had it would show up as positive. Would you form them at the same rate to somebody? We don't know. And I think that's part of a lot of ongoing research. And this is real time. We're only 2 months since we last had this conversation. And, we don't know. But, I think that falls back on cancer patients are good at social distancing. They always have been, they always will be. And, this is the pandemic where now everybody gets to act like them. And so, I think that they need to pursue like they would just in terms of normal infections. And we will learn the rest of this on the backside. But, when a vaccine comes out, I think that we'll have a clear answer as to whether or not you can get the antibodies from it, but they do get the ones from flu. So my expectation is that it will carry across.
Okay. Dr. Weiss, we received several questions about lung metastasis and increased risk and susceptibility. So are there any additional precautions patients with lung metastasis need to take or should be aware
of? I think the short answer to that is no. These questions are very near and dear to my heart because, I did have lung metastases when I was sick and had a couple of thoracotomies for those. This is, in the last century when we didn't have the fancy thoracoscopic surgeries that my partners in thoracic are doing. But the real question I think that people want to know is, geez, if I have now or had lung mets, am I at an increased risk of something bad happening? And I think the answer to that is probably no. And we talked about this a little bit last time. Where I get nervous about folks is people who have sort of chronic systemic lung conditions. Somebody with metastatic disease to their lungs, they may have a tumor in their lung and they may have to have surgery to have it removed. And I'm not minimizing that. That's a big deal. But the entire lung is not sick, just a portion of it. And I do worry more about people that perhaps David has looked after and given them total lung radiation, or somebody who has something like sarcoidosis or some sort of other cystic fibrosis, some other systemic lung problem. I worry about them a little bit more than our patients with solitary lung metastases. What do you guys think?
Yeah, and Dr. Kirsch, maybe you could speak to, because we did receive a question, maybe you could speak to that as well in terms of prior radiation treatment or current treatment and more susceptible, what are the risks or any comments about that?
So I think, if a patient doesn't have COVID-19, they certainly should have their cancer treatment as planned. And that could be if they have a lung metastasis, if they need to have surgical resection or radiation treatment, say SBRT, or chemotherapy. I think they do need to take, the recommendations of social distancing very seriously and minimize interacting with others, especially if COVID-19 is very prevalent in their community. But we have to weigh up the risks of the current sarcoma we're treating versus the potential for COVID-19 complications if the patient doesn't have COVID-19. I think where it gets more challenging, and Dr. Wilkie was just mentioning this, is if a patient tests positive for COVID-19 and they also have a metastasis, then what's the best treatment? And there, I think really there's a lot of clinical judgment that needs to go in. There's not going to be a right answer for the same patient won't have the same answer. Different sarcomas have different rates of progression. So there's over 70 different types of sarcomas. Some grow very slowly, and probably waiting till the COVID infections pass is the best choice. In other situations, some cancers grow very quickly, different types of grades and histology subtypes, and their treating during COVID-19 may be indicated. And so I think certainly it would complicate the treatment and it would increase the risks, but we have to balance the risks and benefits like we do with everything else with our cancer patients. And COVID is kind of lumped in with that as well.
Okay. So Dr. Wilkie, we received several questions actually about whether or not an individual is immune suppressed or immunocompromised, and whether or not they're at higher risk for COVID. So can you give a general idea of what you would consider someone as immune suppressed or immune compromised, and some guidance on that?
Right. So what I've been telling my folks, because I get this question at least 3 times every day. So basically, we're looking at quality and quantity of the immune cells. And when we talk about quantity, there's 2 different types of immune cells that are important. Well, there's more, but for this purpose, let's talk about neutrophils, which are the numbers that goes down with chemotherapy and protects you against bacteria and so forth. And then there's the lymphocytes, which are the immune cells that protect specifically against viruses and help to form antibodies and things like that. So what I've been telling people is that if you're on chemotherapy and you're on a type of chemotherapy where either of those numbers are lower than normal, so the neutrophils dropping or their lymphocytes dropping, which is something that doesn't get as much attention as it probably should, those are the people that are almost certainly having immunosuppression and that are high risk, in my opinion, for a variety of infections, but particularly viral infections. Now, if you're on a chemo pill, for example, or you're on some other type of treatment where your numbers are within the normal range, that's where it's a little bit dicier, because you could still have changes to how your immune system functions, that's the quality, even if your immune cells are relatively normal. So in general, what I say is if you're on treatment, if you have cancer and you're coming back and forth to a clinic, you should presume to be high risk as best you can. And that means following all the social distancing, washing your hands, avoiding sick people, and et cetera. But in reality, I think the only people that we're reasonably 100% sure are in the super high risk category are folks where their immune cells are dipping with treatments. What do you guys think?
Well, I've taken a very conservative stance on this because I like my patients and don't want to lose any of them. But that's honestly why I've taken the conservative stance, which is that anybody who's had therapy within the last 2 to 3 years should be considered themselves at high risk, just because I don't want to be wrong. I would rather have people be overly careful than cavalier. And so I think it's just, you don't know the long-term effects of, what does the immune system actually look like after getting doxorubicin with ifosfamide long term? Is it completely rebuilt over time, or are there holes? And so because of that, I think if you're in a high risk position, but you've had chemo recently, I've just recommended that they fully social distance, fully take care of themselves, because I don't want to be wrong.
Yeah, it's Brian, I had that very same conversation with my family not 10 minutes ago, that if you do it wrong and you're cavalier and you make mistakes and a bunch of people get sick, well, you did it wrong. If you do it right and nothing happens, then it's a little bit more difficult to quantify. So certainly, at least in my opinion, I think going the safe road, like you suggested, and being vigilant about all the things that we've been talking about. I'm pretty conservative with people too, and I'm glad to hear I'm not the only one.
Also, to play the devil's advocate then, okay, so you have a patient who's 3 or 4 months out from finishing up treatment, and she's asking you, look, I need to go back to work. Like, I have to, I'm running out of money. Like, my disability isn't covering food and taking care of my kids. We don't have resources, we don't have support. I have to go back to work. And let's say that this workplace has sort of modest social distancing in place. So they're making people wear masks, but maybe they're not really able to get that every 6 feet apart. Like, how do you counsel a patient when they're putting their priorities in your hands and saying, look, I can't feed my family, but and let's say they have a normal immune system, just to really throw it out there, or at least normal numbers.
But I think that this isn't a this isn't theoretical. I've had this conversation.
Right.
And, you know, the first thing we actually do is try to work with the businesses for accommodations. And I think that I've been amazed at how, you know, somebody who can do A and B can just do A. You know, you don't necessarily have to be the person checking out at the supermarket. There's other jobs there where you could potentially be safer. You know, there's people that have been involved in daycare. That's about the hardest one to deal with, because I mean, that's hard. And so you have to navigate it. But a lot of the places that we've been working with, you know, there are computer jobs that they can do. There are computer jobs that they can do from home for the same business. And so these conversations sometimes, I found HR at a lot of these businesses has been incredibly reasonable with high risk identified patients. And so this is, you know, to get out of being, you know, just the devil, there is sometimes a middle road if you actually bring that up. And most people are, at least around where I've been, have been very reasonable.
Great. Dr. Wise, or Dr. Van Tine, to follow up on that, we know there's been some interruptions in patient care due to the pandemic. If a sarcoma patient's treatment stopped due to COVID, is there any concerns, or what do patients need to be concerned about or aware of in terms of treatment beginning again, and maybe the same for clinical trials if they were in it and then?
So I'm going to take this backwards, because I find that, let's start with clinical trials. Very few places took people off clinical trials. It was putting new patients on that got most interrupted, because the people that were on it, it's very hard to stop somebody that's on a train because the benefits outweighing the risks. But, you know, a lot of the institutions have started partnering. You know, if you can find out that, you know, your synovial patient is positive for MAGE-A4, I can treat you. You may not be treated in New York right now. And so, you know, you may come and live in a hotel for 2 weeks in St. Louis before we can see you. But then, you know, we can move forward. This is, you know, kind of that global group of us have kind of come together, because I would rather take a potentially dramatic and improving therapy and send somebody to Breland in Denver than, you know, hold them back. You know, but alternatively, you know, some people went on breaks just because, you know, they needed to. And most patients, you know, I put a lot of people in clinical trial. A lot of drugs don't work. You know, most 6-week intervals, you know, if you weren't treated for 6 weeks, but you were responding, most people were able to go through that window without a dramatic effect on where they were. And then if there was a lot going on, we worked with you. And so I think this is one of these things where, you know, I think one of the greatest feedbacks I got from a patient about the first one of these was, you know, when she was reminded to talk to her team. You know, that was the most important thing that she heard, because then she called. And that was the greatest compliment ever. It felt like we had actual impact, because you have to work with your providers. And what's wonderful about the sarcoma field is we're all friends, and it's a very small field, but we'll all work together to try to do what's right for the group of patients that we help.
Yeah, if I can just say, sorry, if I can just say one thing. So on Facebook, I have seen a large number of patient posts mentioning that clinical trials are shut down, you know, or saying, oh, well, I can't get on this study. You know, the one thing I will say is that don't assume that's the case, because there are rules of clinical trials that have been changed specifically because of this unprecedented situation. So right now I can do a consent, sign the informed consent over telehealth. We can do virtual consenting now, which we never could do before, and that's IRB approved. My pharmacy can ship experimental drugs to patients if they're oral, which again, never was that happening before. So, you know, don't assume that you don't have any trial options or that you would have to travel and it's not safe. I mean, there are remarkably flexible things that are happening. And so don't, you know, I just want to get that message out there, because that one makes me want to pull my hair out. We are seeing patients and we're evaluating for trial enrollment.
I agree, but if your and just to add to that, if your doctor has that trial normally and can't enroll to it now, there's nothing that they can't coordinate between the centers that can, where you can start it,
right,
and then go back the second they can. Because I mean, this is what we're for. This is our network. This is why when I called Dr. Kershaw and said, will you please do this? He said, sure. I mean, this is why this is such a wonderful community.
So Dr. Kirsch, what have you seen in terms of trial disruption or accrual issues? I know we mentioned earlier that some trials may not be accruing yet, but it sounds to me that there are still things happening with clinical trials. So what have you seen in terms of disruption or accrual issues? And if some trials haven't been able to accrue, when do you see that maybe that will go back to somewhat more normal?
Yeah, so I'd like to echo what the other panelists have said. For most patients on a clinical trial, they've been able to continue to receive the study drug. Some of the activities that were curtailed were the interactions between the patient and research staff, and some of those were transitioned to telehealth type appointments or follow-ups when appropriate. And then at Duke, we did prioritize certain trials that could stay open to continue to accrue for patients, and other studies that were deemed have less priority were kind of put on the back burner for a month or two till we had a better sense of the the pandemic in our area. And fortunately, now we're ramping back up, not quite at full capacity yet, but most of the trials are now back online and they're available for patients. I can say, for example, I'm the PI of a clinical trial where we're testing an immune checkpoint inhibitor, pembrolizumab, with radiation. We've been able to keep that study open and continue to accrue both across the US and its sites internationally. And we do receive biospecimens, so blood and tumor samples are shipped to Duke, and we've been able to continue to do that important clinical trial during the pandemic. I do think that the pandemic, I think, has delayed diagnosis for some sarcoma patients because patients may be reluctant to go get a lump checked out at their doctor, or doctors may not have in-office hours to kind of initiate the process of working up a new diagnosis. But I can tell you that all of the panelists here at our Centers of Excellence for Sarcoma, we're here for you, and we're available to treat sarcoma patients wherever and whenever they get diagnosed.
Great. Dr. Wise, are you aware of, and then any of the panel might want to jump in, but Dr. Wise, are you aware of any research that's being done specifically in regard to sarcoma and COVID, or cancer and COVID, specifically in terms of the connection or anything dealing with sarcoma and COVID?
Yeah, that's a fantastic question. I am not, but at the same time, I don't treat patients with immunotherapy the way doctors Van Tine and Wilkie do. So I'd be interested in hearing what the rest of the panelists have to say, but I don't know of any studies that are specifically looking at COVID and sarcoma. What's have you guys heard?
Well, Brian wrote the protocol. I don't know. Did you have a sarcoma cohort in your COVID protocol?
Well, we were taking a metabolic therapy to COVID patients, but not necessarily those with cancer. But I know that the Cooperative Group Alliance actually has put together a bunch of ideas and a bunch of banking protocols and there are a bunch of thoughts going around about what, these early questions in this, webinar, do cancer patients do worse? Do those on chemotherapy have the same amount? Do they have the ability to get that inflammation that's leading people to get augmented? Or did we fix that with chemo? I mean, there are so many biobanking protocols going on right now that I think the formal protocols where we can look at sarcoma patients specifically will be there. But I think they're right now just in these large, cooperative group umbrella banking studies just looking at cancer. Or at least that's all I'm aware of at this point.
Yeah, I mean, we have, again, those institutional banking protocols, sort of these global efforts to collect data and biospecimens for patients that have had COVID. But to my knowledge, I haven't seen any sarcoma specific data.
Okay. Dr. Kirsch, not sure what we know at this point, but if and when a vaccine comes out for COVID, Is it smart for sarcoma patients to get the vaccine, or is there any concerns that they need to be aware of?
Well, we're all hoping that we'll have vaccine options in the near future. Unfortunately, there aren't any available yet for the general public and our patients, but they are undergoing clinical trials now and testing in people. And hopefully in the not too distant future, there will be some FDA approved vaccines. And different vaccines work in different ways. Some you can inject in dead virus, some you express protein or inject in messenger RNA. And the risk to study subjects and the risks to, or the potential efficacy of whether the vaccine will work could depend on exactly how the vaccine stimulates the immune system. I will say that in general, for our sarcoma patients, when they come in and they need a vaccine against the flu or pneumococcus vaccine or a tetanus booster, we always say they should get it. And I think it's likely that the risks of COVID are going to be with us for a long time. And when a vaccine finally comes, we're going to want to recommend it to our sarcoma patients. But I think that it really, I think, is going to depend on the exact type of vaccine and the details of how it works. And you'll want to talk to your sarcoma doctors to make sure it's safe and that it's likely to be effective for you.
Okay. One of the questions that we received was about patients being seen by a multidisciplinary team. And because of the circumstances and how care has been disrupted in some ways, how are you seeing doctors and patients maintain that team approach? And are there any recommendations for the patients on how they can continue to participate in that and to facilitate that?
Yeah, I'll answer that question. I think that centers of sarcoma excellence, like all of the where all of the panelists today are from, the reason why we can take such good care of our patients is because we have excellent sarcoma surgeons, sarcoma radiation oncologists, sarcoma medical oncologists. We have expert radiologists and pathologists who make the diagnosis and also read all the imaging studies. And we work as a team so that we can give care that's better than the quality of any one doctor by themselves. And I think that with social distancing being such an important way that we're minimizing the spread of COVID-19, we do have to be careful, but we still need to be able to give patients the very best care that we can. And for some patients, that means they will need a physical exam with a subset of those doctors, but maybe not everybody has to do a physical exam. And the other doctors can do telehealth visits and explain how their part of the treatment works, either over the phone or over a televideo type visit. And then once all the doctors have had a chance to interact with the patient, whether it's in person, if it's in person, the patient's usually wearing a mask, the doctors are wearing a mask, and we try to limit the number of people that are physically interacting with the patient to the smallest number that's required. And then afterwards, we're still having our multidisciplinary weekly conference to talk about all of our new patients, but now we're doing it over a televideo type setup where we have a couple of doctors that are in the room where we used to meet as a group of 20, and now there might be 3 or 4 in the room, and the rest of us are doing a video visit like this where we can all look at the patient's images, all look at the pathology slides together, and still communicate together to come up with a consensus treatment that's best for each individual patient.
All right. So we've gotten a couple of questions as well about interacting with others and going back to work. So Dr. Wilkie, as businesses, as we move into these phased reopenings, there are a lot of non-essential businesses that are able to reopen, and offices are having employees return to work. Are there any recommendations for sarcoma patients in terms of returning to work, or should they ask to telework longer? I know Brian had mentioned earlier, maybe if you work in a grocery store, you ask to work in a different area, but in terms of offices and things for people who can actually telework, are there any recommendations to that?
Yeah, so I think that's a lot of what we touched on earlier. I mean, I think so much of this depends on what's the population like where this person or the patient might be. Is this in a hotspot, or is this a place that's more rural with very few cases? How effectively is the business able to do social distancing? And some of that comes from the nature of the business, like Brian said, or sorry, Dr. Van Tine said, if it's a grocery store, if it's healthcare, teachers, hairstylists, things like that. There's different issues with all of those particular occupations. So, and then the patient themselves. So what kind of treatment have they had? How recently? All of these different things kind of factor into it. So, I think if more and more of these businesses are moving towards telehealth, just for example, my father works for Amazon, and Amazon is not going back to in person. Everybody's going to telehealth from now on. And I think, there's basically businesses that are very set up to do telehealth, and I'm sorry, not telehealth, working remotely, or basically working from home. So if this is a business that is able to do that, I think that's the safest thing. And so for patients that have that capability, for sure, I think it's important that we take advantage of that. But, just listening to what Dr. Van Tine said, if we can work with HR, if we can figure out creative ways to keep you safer, that's probably also in your interest.
I'd like to play on that. I have the fortune because St. Louis, has a very, we shut down early, we opened up late, we don't have a lot of hot pockets. So, I went and got my hair cut by an actual stylist. And what was interesting is what I thought while getting my hair cut is the world is now safer for cancer patients in general. The stylist had a mask on, I had a mask on, everything was being cleaned. If this was the world for chemotherapy patients, this is ideal, right? And so it's actually safer if you go into businesses that are respecting what should be done. If you stay away from, going into places where no one's wearing a mask, this is an ideal world for most people because it's actually safer now outside of the virus, for, bacterial infections and normal viral infections than it ever was. And so, you can see this on the other side of it, where this is actually an opportunity where if the environment is being well managed, you can probably feel a little bit safer also. And so I was just, it was exciting that in a lot of ways it's safer. The hospitals are safer. We're all now wearing masks at Barnes and Jewish. You can't come into the institution without wearing it, and so, the infection rates in the hospital are way down. And so this is actually a positive, and hopefully some things that don't drift back. And because it does create a safer world for sarcoma patients.
Yeah,
Glass is always half full with you, Brian.
We're finally following all the advice that everyone has said all along, right? Wash your hands, stay away from people, don't cough and sneeze on each other. This is common sense stuff. It's just now we're actually finally doing it. And it's like, this is going to help flu season. This is going to help for our regular common colds, rotavirus, all this stuff. That sometimes becomes an issue, or norovirus. So I think we're actually doing what we should have been doing all along. So.
Yeah. So, Dr. Kirsch, we'll start with you, and then others may have some thoughts about this, but how do you address and alleviate sarcoma patients' concerns about, there's so many conflicting guidelines going on. We all know so many things change just from day to day, month to month, in the last time we all got together. What advice or thoughts can you give sarcoma patients who are watching the news about the reopenings, and some places are reopening, some aren't? And what advice are you giving patients, or maybe to the folks participating in our program today?
So I think that it's critical to understand in terms of COVID-19, what the prevalence is in your community. I think you can watch the news and see what's going on in another state or another country, and that's not what it may be like outside your door. And so you really need to talk to your doctors and have them help interpret the risks for you and your community. I think going to get a haircut in St. Louis may be fine today, but there might be other communities where that risk would just be too high for a patient that's undergoing chemotherapy, and even if they're wearing a mask, because the spread of the disease is so much in their community. The other thing we haven't really touched on very much, but I think is also true, is that the age of the person that gets COVID is really important in terms of how they'll be able to survive and whether they'll end up in the hospital or not. So if we have a patient that's 75, that person may be going to get the haircut, maybe that's too much of a risk. But if it's a 25-year-old sarcoma patient and they're otherwise healthy, that risk may be okay if the prevalence of the disease is low in their community. So it really has to be a very carefully calibrated response to, and sometimes, the politicians that are making these decisions are listening really well to the doctors and scientists that they work with, and others seem to be opening up communities before maybe they're totally ready. And so just because the politician says it's okay, I think you should still probably check in with your doctor that's taking care of you to check to make sure in your specific community it's safe to go out and do things.
And one question before we kind of go into final thoughts, because we're sort of running out of time here, but this question came up a lot, and we've answered this, I think, in different ways, but I think specifically people are very concerned about this. They've been quarantined away from their family, their grandchildren, their children. They haven't seen them for months. And any thoughts on whether or not, I can see my children, I can see my grandchildren, I can have, be around more people? Does anybody have any thoughts on that?
Well, I think that I'll take the first stab at it, because this is all of our lives, isn't it? My mom and dad are both 83, and they live just up the road. And ordinarily, they'd be having a cookout with us today because it's Memorial Day weekend, and that's not happening. I think this dovetails very well with what David was just talking about. If it seems to you being the sarcoma patient, that we're making this up as we go along, it's because we're making this up as we go along. We're just trying to do smart things that make sense, that protect you as best we can. What are some things that we know? We know that older people, like David said, are at a higher risk of getting sick, and we know that those patients don't do as well when they do get sick. We know that certain professions, certain occupations are more at risk of getting sick than others. The four of us are all certainly at higher risk than someone who hasn't been going into the hospital every day for the last month. Those things are all true. So again, going back to what David just said, you have to put all these things together and use your common sense and talk to your sarcoma team and your sarcoma doctors. If nothing else, you'll bounce these ideas off another person who is thinking about these issues a lot. We're all thinking about these things a lot. We all want to help you be safe. So it's a multifactorial thing. Your best defense right now, I think, is your common sense. What do you guys think?
I'm happy to say I practice what I preach. Both my brother and I are in healthcare, and neither one of us will see our mother, who also has a blood cancer. And so whether it's sarcoma or, something like Waldenstrom's, you have to risk assess your situation. You have to say, the family that's been homeschooling their kids that has not gone to the supermarket in 3 weeks is probably low risk. Whereas I have to have been exposed by now. I don't see how I haven't been. And so you have to risk assess your situation. And, I think this harkens back to our first webinar, where common sense, guidance is probably what we're all recommending, which is if it doesn't seem safe, don't do it.
Mm-hmm. Okay.
Yeah. I agree. I think you kind of hit the nail on the head there. You have to look at the individual situation, the area, all of these different factors play in. Hopefully antibody tests are coming. I don't know if you guys have we didn't really touch on that, but I don't know if your institutions have antibody testing yet. we are testing our healthcare workers, starting with the front line, the people that are actually in the ICUs taking care of COVID patients. And although we don't really know 100% yet what that means, because you've been exposed or because you have antibodies, if you're immune and you can't get it again, I think we're going to learn that as more and more of this stuff gets done. So, it's going to expand, it's going to become more available. And I think until then, you have to live. And at the same time, we want everybody to be as safe as possible. But I agree, common sense.
Yeah, can I just follow up with what Dr. Wilkie said? I think I think COVID's going to be with us for a while, and it may be a longer time than we would like before we have a vaccine. And so I also think that if you're going to see your family, it's important that you do it in a way that minimizes risk. And so to maintain physical distancing and to wear masks, and I think to avoid kind of like a potluck lunch and have everybody come where they've got like a sandwich that's already prepared or something like that. So you're not sharing things. And so I think there are also, I think it's going to be unrealistic to expect people not to see their children and grandchildren. Let's say this goes on 2 or 3 years. But when we do see our family members, we need to minimize the risks, even if we're taking those risks in those settings.
That's great. Well, we're about out of time, and on behalf of SFA, I want to thank Drs. Kirsch, Weiss, Wilkie, and Van Tine for joining us again and for helping us to continue this very important discussion. I also want to recognize that all 4 of our panels are SFA grantees. Dr. Wilkie is our newest grantee, so congratulations, Dr. Wilkie. SFA's recognition of Dr. Kirsch, actually his work goes back to 2010, when Dr. Kirsch was the recipient of the Advanced Clinical Research Award that SFA funded through ASCO's Conquer Cancer Foundation. And he also received a grant in 2017. And last year, SFA supported his work through a project with SARC that SFA funded. But we're also proud to have supported both Drs. Van Tine and Weiss with multiple SFA research grant awards. So we very much appreciate all of your commitment to the sarcoma community and to sarcoma patients. I also want to thank everyone who joined us today and submitted questions to the panel. Our goal at SFA is to facilitate and provide a platform for sarcoma patients to get questions answered and to help navigate this very dynamic situation. We remain in an uncertain time, especially as we begin the process of figuring out what normal life will look like as society begins to reopen. So SFA continues to be available to provide support to the sarcoma community. And please be sure to continue to follow us as we plan to have more educational webinars and discussions as we go forward. And also, if you have any ideas of webinar topics you would like SFA to host, please send us your ideas to our programs@curesarcoma.org email address so we can see those. But thank you all again, and we very much appreciate it. Lori?
And thank you, Brandy, and a big thank you again to all of our panelists for being with us today, and a special thank you to everybody who tuned in on this Memorial Day weekend to learn a little bit more and connect as a community. So we thank you for joining us as well. Just a reminder that this session has been recorded and is going to be made available. We will have a link posted through our website. We'll also be sharing that information through social media, and we'll give you an email reminder of when that link goes live as well. So with that, we'll end today. Thank you for joining us, and we'll see you next time. Bye-bye.
Thank you.
Bye-bye.
Bye, everyone.
Happy Memorial Day.
Stay safe.